I think for anybody who takes care of patients, if you can't understand where Dr. Edwards is coming from about the burnout, the grind, and everything, then either you're a saint or you haven't done it long enough yet, and it will come. But then everything, of course, that we've talked about since, and just these last clips leading into this talk, it highlights, again, why we all sit here and why we all do it is to take care of these patients. And sometimes it is frustrating, and sometimes they're very difficult, and sometimes you just kind of want to scream at them. But when you get to see the outcomes and you get to see them change their life, you understand why they're so miserable. And I think taking that little bit of extra time to understand why people are in that situation gives all of us a lot of empathy. Yesterday in clinic, a patient that was on my schedule, and I knew they were coming. I saw them on my schedule. I've actually known them my whole life, and I just thought, oh boy, I'm dreading this. I don't want to have this conversation. I had my own preconceived thoughts as to why they were in this situation, and by the end of the meeting, it was totally different, and I was able to connect in a way that I never really even really thought of. And so with that, I think just emphasizing that it's really all of us that makes Summit successful. If we don't have the participation and buy-in of all of you, we are really limited on what we can do. And it's really that outside of the technical that we need you for, right? We can do what we do, but that's not enough. That's not going to fix that patient. There's so many more things that have to happen. And that's where, you know, that you're not here for us, like we're kind of here for you, because without you, we can't do these things, okay? All right, so this is a tour talk, so it's a little bit longer, so I'm sorry it's not only 8 minutes. We'll try to keep you awake long enough to make it through. So neuromodulation is a big focus of my practice. I spent a lot of my career and my energy on this kind of subspecialty of neurosurgery. It's not all I do, of course, but it is a big part and something I'm very passionate about. And we've talked about how we can deal with the biomechanics of the spine, and we deal with pathologies when things go wrong. And a lot of the things that we've done in medicine have been reactive. If you develop a tumor, we'll cut it out. I think neuromodulation gives us the ability to not necessarily go in and remove things or disrupt things, but to take a system that isn't working right and how do we hijack it, or how do we work around it? How do we make it do what we want it to do? And I think that's the next phase in medicine, to be able to control things. Pharmacology does this to some extent, but we have all the negatives. You know, we can put chemicals in the body and we know how they react on this receptor we want them to, but rarely is that receptor only exist in that location. It's going to affect other things, and that's where medication side effects and everything come from. So the more that we can kind of isolate our impact and just do what we want to and don't do anything else, then the better off we are. And I think that's what neuromodulation attempts to do for the central nervous system. And so this encompasses a pretty huge area. You know, you might think, well, I've heard of this, but I haven't heard of that. I didn't realize that existed. So I'm going to kind of go through pretty quickly some of the areas where neuromodulation has made a big impact. And some of this stuff is common disorders, and others a little less common. So I'm going to start off with epilepsy. And epilepsy is not that unusual. It's not that uncommon. It's a complicated issue. For anyone who's dealt with it, it can be really frustrating. Medical refractory epilepsy is not unusual. The number of patients with epilepsy that have complete seizure freedom, where they don't have to think about it or worry about it, is not necessarily that big. And so this device, or there's really no other device for this yet, but this device came out, and I was lucky to be part of some of the very first implants that were done in the United States in about 2014, 2015. And this NeuroPace device is able to basically listen to the brain constantly and then provide a response, an electrical response back to the area of the brain that is not behaving appropriately, and stop it from spreading abnormal electrical activity and result in seizures. This typically is preceded by what we would call invasive monitoring, SEGs, stereotactic implant of electrodes or things like that, This picture on the lower left corner, it kind of looks like a hot mess. And I might reference this type of picture later, but there's a lot of things going on here. The skull has been opened in multiple pieces, and that's because we had to open up to be able to put grids over the surface of the brain. Those grids stay in place for a week, 10 days, and the bones go back on. We close that wound, but those wires are coming out of the patient, and they set in an EMG unit, and we watch and wait for them to have a seizure. And then based on when those electrical signals are picked up on that grid, we can pinpoint where the abnormality is, and then we can go in, maybe surgically resect it, or maybe that's not a good option because it's way too close to a motor strip or something like that. We're able to place depth electrodes or grids on the surface and then connect them to this device, which is implanted, recessed in the skull, and listens 24 hours a day for these abnormal firings to occur, and then responds with a burst of energy back to that area and stops those seizures from becoming clinically relevant. So this is a really cool kind of frontier kind of procedure for patients that there really haven't been very good options before. Still relatively primitive. I'm excited to know what in 50 years from now. I won't be alive in 50 years probably, but at the end of my life, how this is, how we're going to use this technology to do such amazing things. Deep brain stimulation, I've talked about my very first conference here 2 years ago. I talked about deep brain stimulation for movement disorders. Deep brain stimulation is now also used and FDA approved for epilepsy. Placing these electrodes in the anterior nucleus of the thalamus, it's able to provide this electrical stimulation into the brain and does a fairly effective job at helping to manage seizures, particularly those seizures that aren't so focal that you can't go in and remove a lesion or fix that one problem. And so this is becoming more and more common as well. Okay, again, still on epilepsy, but a very different type of procedure or location of the stimulation is a vagal nerve stimulator, where we can surgically dissect the vagus nerve in the neck, and we can wrap these electrodes around the vagus nerve, and it provides both afferent and efferent interaction on the vagus nerve to help reduce seizure frequencies, particularly for more generalized seizures. This technology has been around for quite a while. This isn't a really high patient population, and I think more importantly is most of the patients suffering from this tend to have public aid, and there's not a lot of money in it, and so there's been, to me, a significant lack of investment to help take care of this patient population. There have been some recent advancements with cardiac sensing. So I mentioned with NeuroPace, it listens and it's actually watching EEG readings and then responding whenever it senses something that's abnormal. For this device, it indirectly evaluates for seizures by listening to the heart rate. And when the heart rate increases in a non-physiologic way, that's an indication that a seizure is starting, and then it increases its output and provides burst stimulation, and that does a much better job of helping to control these seizures. And so it's become much more effective with the addition of this technology. A simpler surgery, less risk in general. I mean, the carotid artery is right there close by. The jugular is right there. The vagus is in a sheath along with those vessels. But we're not drilling holes and passing electrodes into the brain. So this is a reasonably good option for a lot of patients and is more common, at least up to now, compared to the cranial strategies. Okay. So moving on to movement disorders, deep brain stimulation that I already mentioned that's used for epilepsy, but in this case is used more for movement disorders. Parkinson's, tremor, this is a more classic indication. We can target certain nuclei in the brain and we can interact with this motor relay that exists. A little bit more simple, being able to look like the STN. So this is a pathway, simple version of how dopamine and the lack of dopamine results in Parkinson's disease and all of the symptoms that come along with that. So if we can hijack the system, implant something in the STN or the GPI, we can kind of bypass that lack of dopamine and get the system to ramp back up the way that it was always supposed to. These are awesome surgeries, probably what really brought me to the world of neuromodulation as a resident. Being able to watch these surgeries in real time, typically done awake, and we get to watch these tremors literally disappear with the push of a button. They're fantastic cases, and they can be very life-changing for patients who need it. access to this type of technology is not anywhere near where it should be, and that's for a lot of different reasons. But with advancements in technology, we're able to do these surgeries a lot simpler than we used to with more complicated techniques. And so the ability to do these, say, asleep and get accurate placement very reliably is kind of where we're at now, and that actually is occurring. So again, targeting certain nuclei is what's going to give us the outcome that we're looking for with these movement disorders. Okay, headaches. You might not necessarily think about headaches in here, but headaches are a big problem. Headaches are hard. I would say the only thing that even comes close to approach back pain or spine issues as a very, very, very common complaint and reason why patients' quality of life is low or reasons that they seek care. And headaches, the problem is that they're so diverse and they could be coming from any number of things. And so you can't apply one type of treatment and treat headaches. It just doesn't work that way. And so there's been big advancements pharmacologically with migraines, with some of the new medications that are out, and that's fantastic. But if you have a patient that has neuralgia-related headaches, it tends to not be very effective. To kind of complicate it, some patients will have a predisposition to migraines, but it will be triggered by their neuralgia. So they have occipital neuralgia or something similar, and then that will trigger and lead to a more classic migraine, which is pretty miserable. And particularly challenging with neuralgias, they tend to be very frequent. It's not, I get one, once a month or even twice a week or something. These tend to be fairly constant. The pain never really seems to go away. And so this is another area where neuromodulation has a lot of things to offer. The picture with the forehead device is a transcutaneous device. I'll mention those types of things. But even if you recognize the primary pathology as neuralgia, it doesn't have to be occipital. It could be supratrochlear or supraorbital. And so treating one type of neuralgia with the treatment for another is obviously not going to be effective. So again, this is an area where reimbursement hinders our progress, and that's already been mentioned today. So FDA approval is very expensive, and so most of the devices used for these are off-label use. And that's great, and they do work amazingly well, but they're not built specifically for this indication, and so that creates some technical issues for us. But in general, we're able to place these electrodes over the greater occipital nerve, specifically for occipital neuralgia, and we can implant these electrodes in that location. We always do a trial first to see if it's going to be effective, and the patient gets to test it out for a week, and if it works well, then they want the real deal. And for the permanent implant, we then have to implant that generator somewhere. So it's either going to be in the flank typically or potentially in the chest, like you can see the way that this patient is positioned here. So this is a patient, a pretty unfortunate young woman. The middle picture has those red dots. Those red dots outline a craniectomy. She had about, I'm pretty sure she said 15. She had 15 suboccipital surgeries to address a posterior fossa cyst, and there were a lot of complications. The cyst recurred, it had to be refenestrated, then it got shunted, and then the shunt clogged, and then the shunt got infected, and so on and so on. And unfortunately, as a result of this, she was left with just constant debilitating occipital headaches for about, I think it was about 6 years, and really nothing, never had a day without a headache. Raising children, all of those normal life things. And so the craniectomy obviously presents with some challenges on how we can somehow intervene with this and increases the risk. This craniectomy site has sunken in, which they typically do, and created a pretty tight angle right around that bone edge. And so instead of coming usually from a more medial to lateral approach, we came in lateral to medial and placed the electrodes in a little bit of an atypical fashion, but we're able to get good coverage. And honestly, her headaches were essentially gone. And if the stimulator were turned off, the headaches would be back, within an hour, she would be back to the headaches. So highly, highly effective. And honestly, of all of the stimulation I do, occipital neuralgia is probably the most universally successful intervention, but is not FDA approved. And so we're working on that, but it's slow. Okay, a lot of devices that are obviously meant to target things that aren't invasive. So can we do something that's non-surgical, doesn't require an incision or an implant? And so there's a lot of things that are trying to capture this. And so multiple devices, the one I mentioned with the forehead device is one of them, other cranial attaching devices, and then the one in the top corner there, you can see it around the arm. And it actually is providing electrical stimulation to the arm and is meant to retrograde feedback, kind of like a vagal nerve stimulator would, and help control headaches. I don't doubt that all of these may be beneficial for some patients, but identifying the right patient that's going to be, benefited for this is the challenging part. Because I think I can confidently guarantee that stimulating, the upper arm is probably not going to be a universal headache treatment for every patient. So trying to help improve this and move this technology forward. This patient's a young nurse, works at the university up in Salt Lake. And here you can see she has both occipital and frontal leads. With the stimulator on, the headaches are gone. Within 30 minutes or so of the stimulator being off, the headaches will come back. The technical challenges with this, again, is that we're typically using stimulators that are meant and designed for other things, and we're trying to apply them to this application. And so we end up having to implant those devices all the way down into the flank, or again, reposition or do something to get it into the anterior chest. Newer technologies are finally in development. Consulting with a company out of London, that small little device you can see is going to be intended to go under the scalp, where it will live there locally, and then the wires are just right on the head. You don't have to worry about what movement of the neck and the back and all of those things are going to do to those wires that are having to traverse those areas. And so I'm very excited to see where this goes because I know it's going to be effective because they are so very effective already. And this will just make them a lot more enduring for these patients. Okay, so kind of jumping from pain into something that's a more functional issue. So I don't know, most of you are probably familiar with hypoglossal nerve stimulators, a new device called Inspire that came out that wraps around the hypoglossal nerve as opposed to the vagal nerve and provides muscle contraction. And so this is able to allow opening of the airways while people sleep and is an effective treatment for obstructive sleep apnea for certain patients. Okay. Again, trying to balance invasiveness versus effectiveness. There are devices now that are transcutaneous. They don't have implanted generators that are inside the body like most of the existing ones do. And so these are little small wires that have transducers or ways that you can communicate through the skin. And so those wires can be implanted, and then communication from an external source can be used to activate those wires and get them to provide a field stimulation. And so these are being utilized. A lot of these are meant to be temporary, so in for a month or two kind of thing. And some of them are meant to be long-term, but you have to balance the implanted device, implanted generator source, all of that where it's kind of self-contained versus something more like this middle picture where you have to have an external device that's going to then power that. And depending on the patient, one may be more advantageous than the other. So this is really a patient conversation and why you might choose one versus another. I think the most exciting thing to me about this technology is it just shows where we're going to be going and what we're going to be able to do to minimize the size of these implants, charging burden, maybe even self-charging devices. AI-based systems are just kind of starting to be utilized and investigated, and so there's just a lot of really exciting things that is going to help this technology move on to the next phase. All of which to help these patients, a lot of which have kind of a unique problem or a unique situation. Spinal cord stimulation has been around quite a long time, and I would consider probably the workhorse for most chronic pain neuromodulation procedures. It's not brand new. I do a lot of neuromodulation, and it's rarely that I'm patient doesn't ask me in a week, hey, how long has this been around? And I say, well, the first one was implanted in a human in the 60s. FDA approved in the 1980s, and they just can't believe that it's actually been around that long. Now, wasn't that fantastic? It's certainly gotten better with time, but it has been around quite a long time. A couple of pioneering neurosurgeons that utilized cardiac pacemaker devices and thought, hey, this is electrical. We work on the electrical system. We think we can use this for our needs, and that's kind of where it all began. Okay, this picture I've had with me for about 12 years, and I would say that this has evolved and changed. And I would say it's just simply not so clear cut as it used to be. Opioids, when this thing first came out, opioids were pretty, they were pushed very hard in my training. And we all know that the world has changed in that regard, and things have shifted the other way. And that has opened up a lot more acceptance for these alternative treatments, recognizing the long-term negative side effects. And I have a lot of conversations with patients who are very hesitant and tentative about something like this, and I understand that. And a lot of their, we talk about a lot of their reservations and why they have concerns. And I don't talk to them about, well, hey, this will work better. I say, this is what you're doing now. This is the pain that you have. Are there things that you wish you could do that you can't do because of these symptoms? And that's really where the focus is. And I don't really care how you get out of pain, as long as we can get you there and can get you functional, right? Back to activity, back going to your grandkids' sporting events and all these things that you've had to give up. And the things that you've had to change about who you are, that's not a solution, right? That's not a good alternative. Well, it hurts when I exercise, so I'm just not going to exercise anymore. It hurts when I travel. I love to travel, but I can't because it hurts, so I'm just going to stop traveling. I say that there's a better way, and if we can provide you with the ability to do those things, then it's certainly worth a consideration. And I think neuromodulation is moving earlier on this paradigm. Not so much, hey, after you've burned every possible bridge, then I guess you can think about it. The technology has definitely improved. There's no question. When I first started training, I really didn't like spinal cord stimulators. I thought they were terrible because they didn't work that well, and patients only did so okay. They were hard to deal with. They weren't always the most happy because of their pain, but everything has changed. And the effectiveness has dramatically increased and dramatically improved. And what we can do with the stimulation now is it's not a light switch. It's not on or off. The things we can apply make all the difference. What works for one patient doesn't work for the next patient. And neither one of those patients are going to benefit from what the third patient benefits from. And you really have to approach it, and you have to know what the patient's pathology is. You have to know what they're complaining of, and how do we meet that? How do we match that? So the more commonly accepted, and in general, unfortunately in our world, accepted means insurance will pay for, right? The most commonly accepted things, post-laminectomy syndrome, previously called failed back syndrome. So previous back surgeries with chronic pain, complex regional pain syndrome, diabetic neuropathies, and some other post-procedural type pains. Those in general are pretty well accepted. A little bit less common indications, or less commonly accepted indications, but very effective, non-surgical back pain. Patients who've never had back surgery. I don't think as a spine surgeon my surgery is going to help you, so why would I put you through that? Let's try something else instead. Restless leg syndrome, I've seen amazing results with that. Central pain issues, also show a few of those patients later. There's all sorts of neuralgias, iatrogenic nerve injuries, and these are highly effective and they work very, very well. Relatively straightforward, previous back surgery, chronic back pain, likely leg symptoms, thoracic spinal cord stimulator, works very, very frequently. I do keep track of my numbers, number of trials performed. I haven't had an unsuccessful failed back trial in the last year. And really don't ever expect to. So a little bit more complicated, and this is where the plasticity of neuromodulation is so important. So this is a patient who's obviously undergone quite a few things, having undergone surgery significantly, multiple both anterior and posterior surgeries. He's got a spinal cord injury that may be from the pathology that required the surgery. Maybe it was from the surgery itself. Fortunately, it doesn't really matter. He has chronic neck pain, shoulder pain, and some arm symptoms. The problem is you can't really get anything in that epidural space because of the previous surgery, so this is very challenging to be able to appropriately place this. So this has to be done through an open approach as opposed to a more percutaneous approach. So dissecting down, and basically right at the very top of that decompression from before, we're able to access the epidural space and tuck leads behind C1 and C2, which is kind of the optimal place to treat neck pain in general. And patients did very, very well. Okay, makes a big difference. Very similar patient, previous neck surgery, posterior fusion, you can see. We just kind of sneak in above it, do the minimal exposure we have to, place the leads in the epidural space, and trial them. These patients have the same 1 week-ish trial, and if it works well, then we put in a permanent system. This spinal cord injury was from a motor vehicle accident. The patient had spinal cord injury, had to have decompression and posterior instrumented fusion. He has quadripresis now, so he can't move his arms and legs very well. He's very stiff and rigid. He has horrible neuropathic pain, kind of all through his body. And as the pain gets worse, the rigidity gets worse, and obviously his functional status is poor by our standards for sure. Can't really walk independently, has a hard time, particularly if his spasticity is bad, being able to manage his own care, right? And so neuromodulation in this application, if you remember my talk from last year, we talked about spinal cord injury, and it's been exciting and fun to see some of these patients do well. So implanted trial leads for this patient, and during the trial, the neuropathic pain was dramatically improved. The biggest thing, even for the patient, he said that the pain improvement's fantastic. He said, but I can open and close my hands so much easier than I could before. And that simple capability that we all take for granted makes a huge difference in this patient's life. Okay, the revisions. So these are revisions. This patient who had a stimulator implanted was working quite well for his leg symptoms, which when it was implanted was his primary issue. But things changed, right? 10 years later, his back is really bothering him. He has a lot of back issues, previous back surgery. And so can we just move the leads to a different location and get better outcome? Maybe. But I don't really like just moving them and then hoping for the best. So I kind of like to know, is this going to work? So for this patient, we basically went around his existing leads and drove some temporary trial leads up over the top, and for a week tested it out again. Turns out he had much better back coverage, had dramatically improved coverage of his pain, and so we know where to go now. We know where to target. Went in with the permanent implant. Once those leads are kind of encapsulated and scarred into place, and if you remove them and then try to go in, sometimes you'll run into obstacles and you can't see them at that point because it's now just scar and you don't see that. And so most of the time I like to go in with the new leads so that I know where my barriers are and I can work around them. So in this case, we split the difference, went in between because we knew we were going to stagger leads, and so we wanted to have them as close to midline as possible to make sure we could get bilateral coverage. And we did that. Once we placed the new leads in between, then we removed the old leads and just left the two final ones in place. Patient implanted, had a stimulator for about a year. It worked remarkably well. 70-ish% pain relief is what she was reporting. She suffered a fall down some concrete stairs. Reports that as soon as that was over, she lost efficacy of her stimulator and didn't work anymore. Interrogation system said it worked fine. Nobody could find out any issues or problems. Went back to the previous implanter and everything and said, hey, there's nothing wrong with this. It's great. It's fine. I don't know why you're still having pain. And so it just didn't make sense. And I've seen this enough times now that I thought, this still could be a generator-related issue. Well, we don't know. Did the leads move a little bit and they're in a funny place because she was feeling stimulation in new locations that she hadn't before? And I can't answer that just by looking at a picture. So we implanted new trial leads at a lower location where we would target had this patient been coming in, from the get-go. I thought, well, these leads seem a little high. Let's try going a little bit lower. And then we bypassed her existing generator, plugged into her old leads with some adapters and tunneled them externally. And then we were able to test now both her old leads without the battery and her new leads all in the external world. And turns out the generator was a problem because she got good coverage with her existing leads, but got better coverage, over 85% relief, utilizing the top 4 or 5 contacts on the new leads and the bottom contacts on her old leads. So we removed all of this then at the end of the trial, planted new leads in the right location, new battery, and she's doing great. Similar patient underwent a paddle. The paddles are great, they don't move, but they're big and they're bulky. And so this has been in for a long time. She was starting to have issues with the battery because it was getting old, but she was also getting no back coverage, and she developed mid-back pain, which was her #1 complaint at this point. So we went around her existing paddle with trial leads. We're able to sneak around, place them up higher to try to get all the way up to the mid-back, in between the shoulder blades, and then also down to better treat her low back pain. And those new trial leads covered all of her mid-back and low back pain. So then we can come back in, either leave the existing paddle where it is to treat her legs, or we can remove that, unitize the system into one system and one generator. She actually had 2 generators when I met her. Okay, you look at this spine picture and you're like, well, that doesn't look that bad, right? This patient has pelvic pain. Woman, horrible pelvic pain. She's an avid bicyclist, which I guess is maybe the cause, but basically can't sit in a chair. And anytime you'd walk in the office, she would be on her knees facing the wall because she couldn't stand to sit in a chair. She'd had an ischial bursa resection at the university, thinking that if they did that the pain would go away, and it made it worse. She had PRP injections and everything you can imagine. None of it helped. She had hydrodissection of pelvic nerves. Nothing worked. And so I said, I'm not 100% sure. I've seen this be effective in pelvic pain, and we were able to perform a trial. It worked remarkably well. We implanted her, and she's claiming over 90% relief for pelvic pain, which is very challenging for a lot of these patients. This is also a pelvic pain patient, but in a gentleman. So he's had neck surgeries, he's had low back surgery, he had like a CSF leakage thing that had to be addressed surgically in his upper thoracic spine. He had a paddle placed for a spinal cord stimulator and had complications at the time, and it was removed like within a month of implant. He now comes in 10 years later. You can see the defect I outlined in red, and it makes it really hard to go in that epidural space in this scenario. I wasn't sure what we were going to be able to do, and he had back pain, he had leg pain, he had all that stuff, but his worst pain was testicular pain, and that had become very debilitating. So I wasn't sure where to go. I wasn't sure where we would need leads. I've definitely been able to get pelvic pain in certain areas, but sometimes you need to be lower. And so we kind of went each side around this scarred area and were able to place the leads. And it actually, to me, I feel like it just happened to land exactly the way we wanted it to, because that right lead was down lower, and so you can see that right tail traipsing down lower and moving more to the right, and it was right testicular pain that we were targeting. And he had complete resolution of his testicular pain and almost complete resolution of his back symptoms and leg symptoms as well. And so it's done remarkably well. Waiting for permanent implant on this gentleman. That'll be soon. Spinal cord injury. So these I've seen more of these transverse myelitis type cases, and so sometimes you can see the injury on MRI, and sometimes you can't. So this patient, as well as this patient, these were all patients who came in with an acute event, and since that event, they had non-dermatomal, hard to explain, lower half symptoms, sometimes like hemi-body type pain, but sometimes like right leg, left foot, things that just didn't really jive, don't make a lot of sense. And placing the electrodes over the area of injury seems to be the most effective. And so each of these patients both have over 90% pain relief. For conditions that they've been seen and followed for years and years, all kinds of medications. The second patient I showed, she was very hesitant, very skeptical, and really just said, I've been through so much, you really think that this is going to work? And I said, I can't guarantee any outcomes, but I promise we'll do everything we can to at least give it a shot. And fortunately for us, the technology tends to deliver well over 90% of the time. So this is a type of stimulation that's a bit newer, and it's not meant to mask or treat or cover pain or deal with that type of nerve injury. This is an issue where the muscle, a smooth muscle, has lost its connection to the brain and it's not functioning the way it's supposed to. This muscle is very important for stabilizing the spine. Inner segment intersegmental stability. And so if that muscle's not doing its job, then the paraspinal muscles that were never intended to be the stabilizing structures of our spine have to then step in. And over time, they start to think that they're this muscle, and the other muscle forgets it exists and starts to atrophy. And you can see the atrophy around the spinous process lamina there. And so this stimulator goes in and innervates or stimulates the nerve that goes to this muscle. And it's implanted usually at L3. And instead of going into the spinal canal, this is going out over the transverse process. This is a gentleman that we implanted not too long ago. And it activates. And so once we place those electrodes, we connect it, we turn it on, and we can palpate and watch and feel those muscles firing from the stimulation, so we know we're in the right place. And this is a slower process because, again, it's not just covering pain. It's actually dealing with their issues. Dorsal root ganglion stim, peripheral nerve stimulator, instead of stimulating the tracts as they go up the spine, are stimulating the nerves as before they come into the spine. More targeted, more focal, and has been utilized for many years and can be quite effective. So neuromodulation, obviously, I feel like we're at just the infancy of what we can do with this technology. As we better understand the nervous system and then better understand how we can interact with it, the sky's the limit on the stuff that we're going to be able to accomplish. It's kind of like organized chaos in a lot of ways, but being in the nitty-gritty is the difference between fantastic outcomes and mediocre outcomes or failure. And it really does come down to knowing and understanding your patient, listening to their complaints, and then taking ownership, wanting to be vested in their success to make sure that we do everything that we possibly can. And it takes a whole team to manage this. So hopefully that gives you a little glimpse into neuromodulation and a little, maybe a taste of why I have a lot of passion for it and why I think it is amazing at what it can do for patients' lives. Thank you.